Thank you. Anne has developed these very high-tech cards, which she will now spread among you. So the program says that I will give a quiz. It's a mix of asking questions and teaching, giving a presentation. And I thought we'll make choices by cards, because then immediately I can see who chooses what. Because some questions are also opinions, and it's not about good or wrong, but it helps to start conversations why you've chosen a specific color. And as Jasmine said, for the recording, it is important that you speak by microphone, which makes it maybe a bit less interactive. I think we can also give the microphone to each other.
I can go around.
Yeah, and then give it to the rows. I think we should not throw it, but maybe we can make it a bit more quick than all going to the microphone. So, and of course, this is a very broad topic, genetic predisposition, and it's a difficult topic because there is quite some variety between possibilities in the different countries and the way genetic predisposition testing and counseling is organized. So I try to address all the different ways, and I will talk mainly about how to recognize these children with syndromes in your clinic. Because that is important. We know that approximately 10% of all children with cancer have an underlying genetic predisposition. And sometimes this is important to know to give the right therapy. Surveillance, if the child finishes treatment, it might benefit from surveillance to detect a novel tumor early, and that might also be the case for relatives. Parents can ask for recurrence risk in future children. And also quite important, parents often ask, why did my child develop cancer? Particularly the mothers sometimes have ideas why their child developed cancer and what they did wrong. And this can give an answer to that. So 10%, 1 in every 10 children. And there are different ways to recognize these children. And we see a gradual shift from a phenotype-first approach, the way we always did it in the past, looking at these children, looking at their family history, to a genotype-first approach, just testing all the genes, many genes, specific genes. And I think that there is quite some difference between the countries. So likely you now all have the cards. So I'm a clinical geneticist, but I know that my profession is not available in all countries, or maybe there are clinical geneticists in your country, but not specifically for children with cancer. So my first question is, what is the situation in your country? So I call this genetic counseling. It includes recognizing these children, talking about genetic testing. Is that done by the pediatric oncologist, by specialized pediatric oncologists in human genetics, or by clinical geneticists? Can I have your cards, please? So many clinical geneticists. I see someone over there with 3 cards. So they all like to do it very much, and they're competing. Yeah, some have pediatric oncologists specialized. Yeah. Okay, but also purely by the pediatric oncologists, yeah. So I think clinical geneticists are more and more involved in that, but not yet at all places. And then the other question, at conferences you hear all these stories about sequencing of large sets of genes. Is that already implemented in your center? That's blue, or not at all? Yeah. Okay, yeah, so that's more yellow than blue. So some centers have experience with that, but many don't. Yeah. Okay. Well, often you don't need it, because if these children come into your hospital, then often they already have a diagnosis, but maybe sometimes you recognize the diagnosis. Maybe here we can just shout, do you recognize one of these syndromes? trisomy 21, yeah, the boy in the pink shirt. Beckwith-Wiedemann syndrome, yeah, the boy, right, with the large toe. Trisomy 21, yeah. No, Fanconi, is it? Russell-Silver syndrome. Yeah, the boy left below, he has Sotos syndrome. They often have the pronounced chin and high forehead, large head circumference. We don't see those very often in childhood, but they have a slightly increased risk. And the boy right below has Noonan syndrome. I think we miss these quite often. Yeah. They often have short stature compared to their siblings, but can still be in the normal curves. They have those low set ears, often pale blue eyes, and the downturned corners of the eyes. But you can often group all these features by saying just a very cute kid, and not really dysmorphic, so not very apparent, but a very frequent syndrome. So I think we see these quite often in our clinic. So these, are clinical diagnoses which you confirm by a genetic test. These ones, do you recognize them? Yeah, maybe. I hear yes, but the names can be different in different countries. Can someone shout? Bert, yeah, in Dutch, Bert en Ernie. Yeah. Yeah, that's true. Ninja Turtles, exactly. Yeah. So how did we do this? I think you looked at the numbers, you looked at the colors, and Bert and Ernie at the relative height. So you group these characteristics, and then you know, well, but actually it's just Lego, of course. But we recognize Ninja Turtles. And another important thing is that we are experienced. We've been binge watching. We've seen them quite a lot of times, so experience helps a lot in recognizing such features. Actually, Bert has quite some dysmorphisms. He has a microcephaly, cynophris, low-set ears, the mouth, quite particular. So my first take-home message is, we just did an inventarization, but it is important that someone in your hospital or a few people specialize in it. So if it is the pediatric oncologist recognizing the syndromes, then maybe some of them can be the experts in your clinic. And if you have clinical geneticists, but you see another one each time, and they mainly do adult genetics and a child once in a while, then start talking to them and ask them, can one or two of you be the specialist in childhood cancer genetics, because the syndromes childhood cancer is rare and the syndromes are rare. So it's important that they have a steep learning curve. Because there are many syndromes, and we see these each only a few times a year, in the larger centers, in some centers never. And when I started working in pediatric oncology, I thought, how do I get the right patients in my office? Because, of course, you are dependent from referral by the pediatric oncologist. And then I thought, well, they don't need to know all the characteristics of all the different syndromes. They need to know when they see specific characteristics that they then can refer the patient. So I grouped these characteristics of all these different syndromes. And there are 5 categories, and the first one is broad specific features. So that includes short stature or hyperpigmentation, etc. Then, of course, the family history. Children with multiple primary tumors, then you always need to think of predisposition unless there is a very clear correlation with treatment. Children who experience excessive treatment toxicity and specific malignancies. Don't know what happened here. Well, let's just go on from here. So, I developed a test, which I will get back to later, apparently, in which I ask questions about all these different features, and then the test will tell you to refer a child to the pediatric oncologist. And so I work in the Princess Maxima Center, and that opened in 2018. And in 2019, we decided, well, let's go back and let's see how we are doing. And actually, we didn't use these criteria. We just relied on the experience of the pediatric oncologists. And of course, as clinical geneticists, we were part of the medical boards, multidisciplinary boards, and sometimes gave advice. Well, this child could be referred. And this was in the period that we did not yet implement this extensive sequencing. So this was mainly phenotype-based. And here you see the retinoblastoma center in the Netherlands, because these tumors are still treated in Amsterdam. So we also included them. And in this period, there were 836 new diagnoses, and we recognized the syndrome in 8.6%. And this figure might sound quite remarkable, well known, because all these sequencing studies also come up with such a percentage. So actually, we felt that we didn't that bad. And I would like to ask you, what do you think was the most frequent syndrome? Because what is unique about our study is that we have this national center, and that this is all cancers in one country, so no biases in the population. So what do you think is most frequent? Yeah, I see quite some different, many red, neurofibromatosis, a little bit of blue, and quite some yellow, Li-Fraumeni syndrome. Maybe you're all right. So this is what we found, and so an equal position for Down syndrome and NF1. And we didn't make these diagnoses because mostly these children, of course, came to the hospital with their syndrome diagnosis and then developed cancer. So that was not something we did. And what is characteristic for these syndromes is that they are so easily recognizable. You all recognize immediately the boy with Down syndrome. And of course, the neurofibromatosis patients have these pigmentations all over their body. But some said Li-Fraumeni syndrome, and that maybe is because of these large sequencing studies. There you see that Li-Fraumeni is at number 1. And there are 2 reasons for that. One is that these children you can often not recognize, because often they have de novo mutations and no remarkable family history. And these first sequencing studies started sequencing poor prognostic tumors. And many of those are related to Li-Fraumeni syndrome. So they introduced the bias and had many Li-Fraumeni patients in their cohort. But we might have missed them because we looked at the phenotype. So likely if we start sequencing this cohort, we might find some extra Li-Fraumeni patients. And that is shown here. This is one of these first large sequencing studies. And there you see that TP53 is at number 1. And there are no Downs, but that's due to the bias. They were not included in the study. So here are again those 5 different groups which can trigger you to think of a genetic predisposition syndrome. And we looked back at all these diagnoses that were made. What was the trigger to recognize this syndrome? And what do you think was most important for referral to the clinical geneticist? And then I have to say that we only looked at the patients in whom we diagnosed the syndrome after they came to our hospital, so not the Down syndromes and not the neurofibromatosis. So either family history or specific malignancies. We have the yellow team and we have the blue team. That's interesting. Yeah, so quite some people who say family history, and that's not so strange because, of course, in genetics, that's where we come from, all these breast cancer families, all these colon cancer families, but that's not the case in childhood cancer. And why is that? So most patients were recognized because of their tumor, like in retinoblastoma. We immediately think, oh, RB1 gene. Well, many patients have de novo mutations, as I already told about the Li-Fraumeni patients, much more than we had previously thought. Reduced penetrance, and particularly the novel genes that are now found, these often are genes with very low penetrance. And in childhood cancer, we see more syndromes with autosomal recessive inheritance, so where you have two parents that are carrier and then the disease is expressed in the child, much more than in adult genetics. And that is shown here. So in 58% of the children, the syndrome was recognized after their cancer diagnosis. And here are the different ways or different reasons for referral. And in these numbers are for the children that had only one reason. So in 12 children, it was purely the cancer type. But often there were multiple reasons. So a cancer type plus a family history or plus phenotypic anomalies. But if you look at the purple thing, it's not a circle, then you see that family history only helped in very few cases. And it's really the tumor type nowadays that is instructive. And here are some examples. In rhabdoid tumors, we always think of SMARCB1, sometimes SMARCA4, pleuropulmonary blastoma, strong correlation with DICER1. Choroid plexus carcinoma is one of the TP53 tumors. And that is on a tumor basis, but nowadays we can subgroup the tumors. The pathologists are very active in that, making all these subgroups. And for instance, we have learned that epithelial type Wilms tumor, a rare type, is linked to TRIM28 mutations, and hypodiploid ALL, also rare, but if a child has that, you immediately have a high chance of finding a germline TP53 mutation. And the group in Heidelberg did a lot of research into medulloblastoma, which are nowadays divided in 4 molecular subgroups. And for instance, in the Wnt signaling group, you can find germline APC mutations. The sonic hedgehog group, there even 40% of the children have a germline mutation in one of these genes. The paper was not up to date anymore because after that 2 novel genes were identified. And in the classic groups, 3 and 4, they found PALB2 and BRCA2 mutations, both in the Fanconi way, so on 2 alleles, or heterozygous. So who of you thinks, well, that's a lot of information, hard to remember, or I'm fully in control, I can apply this in my... Yeah. See some red cards. So that's why these tools were invented to help you, because indeed there are so many little facts to know across all these different tumors. That's hard to keep up with that, and new correlations are discovered every year. So based on these 5 different groups, I developed such a tool. And this is one example. So 5 questions are asked about the family history, and if you answer one of these questions with yes, then the tool advises you to refer the child to the clinical geneticist. It's not said that the child has a syndrome, but at least it's good to have a closer look. Some people refer to this as the Jongmans criteria. So a colleague said at lunch, you're the Jongmans of the Jongmans criteria. I said yes, and please don't use them. Because in my book, they did something very smart and much more helpful. They developed a tool which is called the MyPOC tool. And that one is cancer specific. And you can just put it on your iPhone. It's an app. There's also a website. And you can go to that site. And if you see a child with osteosarcoma, you go to the osteosarcoma questionnaire. And then it asks you questions which are very specific for all the syndromes associated with osteosarcoma. And because of all these new associations, it's also very time consuming to keep it up to date all the time. So I'm very happy that people in Canada are now doing that. So forget about the Jongmans criteria and put MyPOC on your phone. And this is just an example from rhabdomyosarcoma. They first ask these specific questions and then also some general questions like in the tool that I developed about the family history. And again, it's a reason for referral. It's not said that then the child should have some syndrome and that you should start looking for it till you find it. So the next take-home message, have a look at the MyPOC tool, but also introduce it to your clinic when you're back at home. We also looked at this study that we did, looking back, what kind of syndromes did we recognize, what kind of genetic testing we did. And in most of these patients, we just asked for targeted testing of one or two genes. So that's very promising for the countries where large gene panels are not available yet. Often you don't need them. You don't need a large panel to find a mutation in the retinoblastoma gene or in the dicer gene. And often the phenotype or the tumor type can help you to just specifically ask for this targeted test. Again, of course, we don't know what we missed in this cohort if we would have applied large gene panels. So the conclusion of this study, by just phenotyping and then referring and doing the genetic test, we found almost 9% diagnosis, but it is possible that we missed mutations. And a study where phenotyping and genotyping was combined is already available in the literature from the Danish group. And indeed, they found a higher percentage, 14%. So likely such combined efforts will help to find more patients. And in the Netherlands, we're currently testing that in the PREDICT study, where we offer both paths to all newly diagnosed children with cancer, the phenotype-first approach, where we apply MyPOC to help the pediatric oncologist to refer the right patients, and the genotype-first approach, where we test a panel with all known childhood cancer predisposition genes. And this is done 3 to 6 months after diagnosis. That is because there are many studies in our center, so we actually have to stand in line. And our study is not essential at diagnosis, so we were asked, can you please go to several months after diagnosis, because people are so overwhelmed by all the different studies. And I think that's good, because indeed you need to talk about this, you need to ask consent, and maybe that's better at a later moment. We first thought about the gene panel, and the 2 PhD students here, Ilya and Anna, have put a tremendous effort in that, because we felt that we really only wanted to test childhood cancer predisposition genes. Of course, there are genes that cause both cancer in childhood and adulthood, and then we would include those, but not the pure adult onset genes. And also not the genes that might be interesting, because we are testing whether this is a good approach in regular diagnostics, and in diagnostics you should not test genes that might be interesting. You should really test the ones that are relevant. So we developed criteria to which the genes should apply. So we said there should be at least 5 children in literature with childhood cancer and a mutation in that gene from at least 2 different families, and there should be extra evidence that there is a real causal relation. And then we checked all the genes according to these criteria and came up with this panel of 140 genes, and that is available on the Princess Máxima Center website. We developed this practical URL. I'm not sure whether it's really practical, but you can also find it on the Princess Máxima website. And the Canadian colleagues update the MyPOC criteria, and we update the gene panel. So we're now already at the 4th version. So if novel genes are identified, we add it to the panel. And you can also contact us if you feel that one is missing. So we're now applying the gene panel, of course, in the PREDICT study, as I just told you, but also in a precision medicine study. And our experience so far is that most mutations were already found in regular diagnostics. But here are 2 examples that we missed: a TP53 mutation in an 18-year-old boy with osteosarcoma and a negative family history, and an ALK1 mutation in a 16-year-old girl who had with medulloblastoma who had a recidive. And the moment that I saw her was just before the publication of ALK1 as a medulloblastoma gene. So we missed it. So we ask consent for the panel, and I would like to ask you, how many people do you think, parents often, or the older children, do consent for participation in broad gene testing?
In the Netherlands.
In the Netherlands, exactly. Yeah, and after counseling, so we don't say, we really explain, yeah. So that's a nice rainbow. 90%, quite some people, 80%, not so many, 70%. Yeah, it's even a bit lower, I learned this last week. 66%. Yeah, so we now asked 512 people, and 66% said, yes, we want to participate. And can you think of reasons why they don't want to participate? Kathy? Yeah. So we asked them first at 3 months, now we even moved to 6 months. And you're totally right, because some people start phoning us. Well, we said no, but we thought about it at 9 months after diagnosis, and can we still participate? So timing is important, yes. Yeah. Other reasons?
Afraid of insurance issues?
Yeah, not that much, but that, yeah, is one of the reasons. Oh.
Please repeat the question, because it's difficult to hear what goes on.
Yeah, so one of the answer was maybe because of insurances, that they are afraid that they will need to pay extra for insurances later in life. Yeah.
Perhaps implications for siblings who are currently well?
Yeah, well, that's very important why people do want to participate. Yeah, that they want to prevent or find tumors at early stage in siblings. So we don't hear that often as a reason not to participate. But some parents don't want to make the decision for their child and want their child to grow up and then make the decision for him or herself. Yeah. Yeah, that's an important one. And I already heard from a colleague from Norway who said, now we are doing it as part of a study, but we think that if we implement it in regular diagnostics, that more people will participate, just because people participate in so many studies and they don't want to anymore. Yeah. What we experience is that people often ask, what do we need to do? What does my child need? And if you say, yeah, nothing, the sample is already in the freezer, but you really need to think about it if you want this, then often they say yes. So the burden is particularly in drawing extra blood or coming extra to the hospital. Yeah. But too many studies and religion, some people because of religion reasons. So the reasons are various, yeah. And I think therefore it's important to really counsel this and not do this just as part of your regular diagnostic without informing patients. I added this slide because I'm often asked, if you look at such many genes, what about VUSs, variants of unknown significance? We find many of them, but because we also have the sequencing data of the tumor, we can also get rid of many of them, because you can immediately look in the tumor data, often also in the RNA sequencing data, whether really is a splice effect, whether there is a second hit, whether there is a mutational signature that fits with the VUS. Yeah, the question is, do you always look at 2 samples? Almost always. For instance, in the lymphomas, not always. But for many tumors, we do have the tumor data is there, yeah.
Do you just sequence as a panel, or do you do WES and look at the WES with the panel?
Yeah,
because the price of WES today is...
Yeah, we do whole exome sequencing, and then we apply a filter and look at the panel, which also means that now that we update the panel at the end of the study, we can go back and again look at the panel as it is at that moment. Yeah. But still, in 1/4 of the patients, we end up with a variant of unknown significance, class 3. So that's the class where you really don't know whether it is benign or not. And we don't communicate those unless we think, well, but the variant in this gene really associates with the tumor of the child, and there is a possibility to do further testing, for instance, segregation analysis in the family. So this is about the doctors recognizing the syndromes and doing the broad panel testing. But in between that are the pathologists who are taking over and also recognize many syndromes. At least that's what we experience in our institute. And I see some people nodding. So they are doing quite some molecular tests nowadays, not only look through their microscope, but also do tests on the tumor DNA. And this is an example of a girl, age 15, with a high-grade glioma. And this is in Dutch, but it doesn't really matter. It's about the genes. So in 3 genes here, ATRX, NF1, and TP53, a mutation was identified. Oh, you don't see my pointer. And then in the last column, it gives the variant allele frequencies. And are you all familiar with this term? Can you raise a hand if you think variant, and that's not strange, variant allele frequency? Yeah? And maybe you know the term, but you do not precisely know what is actually meant by it. But it can be extremely helpful if you read the pathologist reports. And then if you look at variant allele frequencies, you always also need to look at the tumor cell percentage. And that is up here. It says 80%. And that is a bit of a guess, so it can also be 70% or... And that is important to know. If the pathologist does a test on tumor DNA, it's never 100% tumor DNA. There's also lymphocytes attacking the tumor. The surgeon did his best to cut normal tissue around the tumor. So there's always also germline DNA in your sample. So if they do a test on the tumor DNA, they often also look a bit at the germline. And in this case, the tumor cell percentage is 80%, so 8 out of every 10 cells are tumor cells. And for every gene, there are 2 alleles in these cells. And if we talk about variant allele frequency, then we mean how many of these 20 alleles in 10 cells do carry the mutation. And in this example, well, there are 20 alleles. There is a heterozygous mutation in the tumor. That is 8 out of 20 alleles. That is 40%. And then if you look at the ATRX mutation, that says 37%. So likely that is a heterozygous mutation only in the tumor. Then the next one, here we have a heterozygous mutation in the tumor and the other allele got lost. So then the calculation is that 8 out of 12 alleles are affected, and that is 67%, and that likely is the case for the NF1 mutation. And that's what we often see, one mutation on one allele in the tumor, the other allele got lost, and then you end up with this percentage. Now, if the mutation was also present in the germline, then 2 alleles in these 2 germline cells are affected. And then you get this calculation, 10 out of 12 alleles carry the mutation, and that's 83%. And if you look at the TP53 variant, 84%. So as a clinical oncologist, you need to look at this number, and it can be that based on these numbers, you ask a clinical geneticist, can you talk to this patient about testing of TP53 in the germline, because this might be a patient with Li-Fraumeni syndrome. And this girl had a negative family history, so that's not helpful, but in the end, indeed, she had Li-Fraumeni syndrome. So really important to look at these numbers. And if you think, I want to look at more of these cases during these days here, I have some extra on my computer, so just come to me and we can have a look at that, because it can be really helpful. But that means that actually, you need to inform your patients that also when you do just testing on the tumor, that there might come indications that there is some kind of predisposition. So we start doing the counseling when we really look for those syndromes, but yeah, if we also look for these syndromes by doing the pathology test, then I think we should inform them earlier in the process. I think I have 5 more minutes. I have one a bit more complicated case, but if you feel it's maybe nicer to have a question round, then we can also do that. Go on, yeah? Yeah. Okay, then we end with a complex one. Worst moment in my career. It's about ATRT, and this happened now 6 years ago. I counseled this couple who had a daughter with congenital rhabdoid tumor. And we know that these tumors often have 2 SMARCB1 mutations, and in 1/3 of these children, the mutation is in the germline. So I took blood, sent it to the lab, come back negative, and counseled them that they had no increased risk in a future pregnancy. Then this happened. So the mother, she was insecure at 30 weeks of pregnancy, asked for an extra ultrasound, and then they saw an hydrocephalus, and the child had the exact same tumor at the exact same position. So I first thought, what did I do wrong? Went back to literature, did I miss something? Then I thought, sample mix-up. But we did it all over, tested the new child, and really didn't find the mutation. We did Sanger sequencing, MLPA for copy number variants, WES was implemented at that moment, the whole exome sequencing. Didn't find any mutation. There was loss of SMARCB1 in both tumors by immunohistochemistry. So there should, of course, be 2 mutations. When the second girl was born, we could do the SNP array analysis on the tumor, and we saw that both girls lost the other allele. So there was LOH in both tumors. And we saw that it was both times the maternal allele that was still present. So then we knew, okay, the mutation is likely on the maternal allele, but we couldn't find it. And we did RNA sequencing, we did whole genome sequencing. Each time that there was a new technique, I ran to the lab with the samples of this family, and because they wanted to have another child, but were waiting for the prenatal test to come available. And then there was again a novel technique. It's called optical genome mapping. And by this technique, you can find large insertions and large duplications in the genome that are hard to read with the sequencing techniques. And the story is not about the exact technique, but in the end, this helped to figure out that there was a very large insertion in the intron of between exon 2 and 3 of the SMARCB1 gene. And this insertion was a retrotransposon. They can travel through our DNA, and if you have bad luck, they end up at a very nasty position. And that happened here. And we learned that the mother was a low mosaic. So this explained that they had 2 children with this condition. But when the first child was diagnosed, we didn't have the tumor information yet. Nowadays, I could have known that we were missing a mutation in the tumor. So that's what I now always do in these children with rhabdoid tumors. I check what are the mutations in the tumor. And if the lab only found 1 mutation, then you immediately know that your germline test, if it comes back negative, is not informative, because 1 mutation apparently is a difficult mutation. And actually at this moment we have a teenager with a SCOT, the small cell ovarian tumor, and we are missing 1 SMARCA4 mutation. We only found 1 in the tumor. So also there we are now searching. Might take another 5 years before we find it. And when we found this, we could develop PCR primers on the breakpoints. The couple became pregnant. They were 39 then. Calling me every half a year. We don't want to press you, but did you find something? And now they have a healthy son. So this child was tested, and he did not carry the insertion. So that, I think, is a really important message, that you can look in the tumor data, what is happening there, before you start thinking about the germline, because that can really help to know that we might also miss mutations. And then in general, the conclusion is that phenotyping still helps a lot. Also in this case, of course, we knew where we had to find it based on the phenotype. There is a shift to genotype, but I think that we may always need to combine this information and keep thinking about the combined results. Thanks a lot, and happy to be squeezed the next couple of days with all your questions.
Any questions to Barbara?
Hello. How a sender can send a sample to your sender?
How that can be said.
How much that?
Yeah. So of course we have possibilities that are not available in all countries. You can of course contact us if you have a particular case. I don't think that my boss likes me to say yes, we can do the genetic testing for. But sometimes that's not necessary, and it also helps to think together about the case, and that also is what the SIOP-E host genome working group is for. So if people among you are really interested in genetic predisposition, then I would advise you to send an email to me or to Christian Kratz of the SIOP host genome working group. Then you are invited for the workshops. It's really an active group where we think of new surveillance protocols, but where you can also share a clinical dilemma regarding a genetic predisposition, and where we can refer you to, if there is a specific lab interest in a specific gene, it might be possible that you can send a sample, indeed.
Are there any clinical trials active right now that we can participate?
No, I think that genetic predisposition studies often are national and not aiming at international groups. Yeah.
Thank you, very interesting talk. The timing that you mentioned at the beginning, from being diagnosed with the cancer and then being tested for genetic predisposition, I think might also be crucial from what you said. Maybe they will have increased toxicities or something. And I think a big question is still, are we using that information for then adapting treatments?
Yeah.
We just had one case where, or it's actually pretty common, where you have TP53, ALL, maybe then also needing TBI. And could you name maybe some where you are already considering taking this into account, or do you think we are too far away from actually considering that in our treatment decisions?
Yeah, that's true, and it's happening more and more. So, for instance, in the medulloblastoma protocols, they have separate arms for the children with germline mutations. But if you develop such a protocol, you should also think about the possibilities in the different countries. And then I think you should offer testing in the countries where it is possible, because otherwise you are developing protocols that are not useful, or at least specific parts of the protocol. But that indeed is a reason why for some children you need to do it much earlier, and at 3 or 6 months is not fast enough. That's true. And that will be more and more. And at the leukemia meeting last weekend, that was indeed mentioned also, that if you make it part of the protocol, then parents might consent easily, more easy for the genetic testing. Because, for instance, in Italy, a colleague told that many parents refuse testing for Li-Fraumeni syndrome. And then colleagues said, yeah, but if it is part of the protocol and if the treatment changes, then it will happen.
I think your example is very important when we think about hypodiploid ALLs,
Yeah.
who are usually high risk many of them have a transplant indication. The Forum trial has taught us that chemoconditioning is significantly worse in all subgroups. So the question is, if this patient has leishmania, would you go for TBI-based conditioning or not?
Yeah, that was a hot topic last weekend.
This is very difficult to answer, I think.
Yeah.
Carmel, what do you think about this? What would you recommend? Leishmania, transplant indication, which type of conditioning?
I would not go for TBI, honestly speaking.
No. We would also not go.
Even if it is clear that for the Forum study showed clearly that it is a better way to get better results, but this is a very dangerous way.
And last weekend, Uri Tabori was in the audience, who is not a leukemia doctor. But he said these syndromes are so rare, you shouldn't wait for all these years to figure out how are they responding. Sometimes as doctors you need to be brave, and if you have a feeling that you're not doing the right thing for this specific group, be brave and change it. Yeah. But of course the tests then need to be available. Yeah.
If you die from your primary cancer, you cannot
Yeah.
the second.
But I think that's true. But I think in leukemia we have other options after relapsing after transplant. Yet this was not the case, I think, many years ago. But so I think we would have taken the same decision in Vienna as Carmelo is saying.
Yeah.
You said you do the testing 3 to 6 months. How do you make sure you don't lose them? Sorry. How do you find the patients? I'm afraid if we had the testing after 3 months, they would disappear and we wouldn't see them.
So we compare the two paths, and of course referral often happens earlier. And that also gives us
you a diagnosis, and then you take
exactly.
it in after 3 months. I see. Okay.
Yeah, and that doesn't happen in the first week often. But that's also the nice part, that we can do our old-fashioned clinical work before the result of the gene panel testing. So for that reason, we were okay that we were put at 3 to 6 months. Lose them, well, that's the case for some low-grade brain tumors, for instance. And that's also a reason why people don't participate. They have spent a very short time in a pediatric cancer hospital, and they finish that, and they don't want to be part of that anymore. So that's also a reason why some families say no. Yeah.
If you picked up a germline mutation in a sibling, would you have recommendations for specific screening for them in your centre, and who does that? Is that a geneticist, or is it oncologists, or is it paediatricians? Because that's a bit of an issue for us.
Yeah. Well, there are, of course, that depends on the syndrome, and for some there are European surveillance protocols, and for others less so. And if you feel that something is missing, then you can ask the SIOP host genome working group, well, as a next protocol, will you work on that? There is often a difference between the protocols in Europe and the United States, where they're also a bit defensive because they can get lawsuits. So that's the reason why we often develop a new one in Europe if there is one in the United States already. Do you advise? Yeah, of course, yeah. Yeah, and for some syndromes, we centralize that also in the Prinses Maxima Center, for instance, for Leigh-Fraumeni syndrome, because it's so rare and we still need to learn whether it really works and is helpful. And for instance, the ultrasounds for Wilms tumors, we do that in all hospitals in the Netherlands.
So do you have any families that participated in the PREDICT study, but they didn't want to have a feedback about the results?
Yeah, good question. Yeah, so, some parents say that they are very eager to help the hospital because the hospital helps them. And they say, yeah, for science it's good, but we don't want to know. That's not possible. So we don't want to have results of which we think, but maybe they want to know this because this is really helpful to know. So if they don't want to know, we don't want to know. Yeah, so then we don't do the testing. And for that reason, we have this separate consent procedure, because in our hospital we have a biobank consent, and then at one moment you consent for many different studies with the material. But from the beginning we have said for genetic predisposition studies, you always need to ask separate consent.
Okay, that's really weird because in Essen we have the AML study, and when we have the samples and the families have signed and the results are not affecting the treatment, then we don't have to give a feedback about them. And that's why we are able to send to you samples for our testing, but they are not affecting the families.
Yeah.
They're just helping
but it
for
can
the
even be
research.
that the result, so we now know that we find breast cancer mutations more often than we had expected. And if you find that in a little boy, it's not important for the treatment now, but if it comes from the mother...
It's for the daughters that
and
he's
for
going
the
to
daughter,
have.
Exactly, yeah. So we only test them if they have said we want to know. And you could of course say you can also anonymize it, but that's not really possible because these children are so unique. A boy with AML at that age, yeah.
Okay, last question. Sorry if it's the last. I hope it's a good one.
I'll ask to show the cards.
Would you suggest, apart from maybe ethical reason, that in the newer protocols you would implement some genetic testing for all kids, all cancers, because with 10% it's kind of a lot of children, and it's always difficult, for example, if you have a leukemia, which is most of cases in pediatrics, to have some germline samples, because it's in the blood and you do not get germline. So would you suggest like to have a skin biopsy done at the same time with, I don't know, bone marrow or something in most newer protocols, because it would help so much?
Yeah, that's common practice now that we take, but not necessarily for the germline testing, but also to distract the somatic mutations in the leukemia. And your first question, would you advise as well, that is a good question and $1 million question. And that's what we're figuring out in the PREDICT study. And maybe not with such a large gene panel. Maybe we can make one for leukemia, one for... but that's why we are evaluating it in an unbiased population to come up with advices for daily routine diagnostics. And it might be that the answer is not the same for all tumors.